Students, welcome to the fourth in a series of 4 Day in the Life of Hospital Executives. This morning we have the pleasure of having Bryan Randle from Heritage Valley. He is the Chief Financial Officer for that health system. Welcome.
No, thank you very much. Pleased to be here.
One of the things that how did you get to be the Chief Financial Officer? Can you describe your journey in getting to that position?
You know, for me, it probably was a long journey, a lot of hard work along the way, but I really grew up through the ranks of finance. Right out of college, started as a staff accountant at Montefiore Hospital in Pittsburgh, and really worked my way up. Spent a couple of years there, had an opportunity to go to Forbes Health System, which was a newer system that had just come together. 2 hospitals merged at the time, and had some skilled nursing and hospice and a lot of activity going on, and they cleaned house and put a whole new finance team together, and had the opportunity to go there and work as well as a staff accountant. And as one thing led to another, I ended up being there 15 years. Had a variety of roles within the finance shop. Probably one of the best moves for me was going from the accounting side to the decision support and budget side, where I was an analyst. I had Forbes Regional in Monroeville as my facility. I learned a lot about operations, working with department heads on rate setting and charges and new procedures, as well as really working with the administrative team there on a monthly basis to help them understand financials and where areas of improvement could be, as well as working on budgets. And so really got to understand and learn a lot about the hospital and the operations. Became director of accounting and reporting there for about the last 8 years, and then had the opportunity then to go to work for a company called Allegheny Health Education and Research Foundation, which everybody says, well, what was it? It was AHRF. It's interesting, when I first started there, you'd mention the name AHRF around town and nobody knew what it was. Now it's a nationally known name through bankruptcy. It was a great place to work. I worked there in physician finance between Philadelphia and Pittsburgh. We were in the acquisition mode in the mid-90s that most organizations went through to build physician networks under capitated payment arrangements. Owning patient lives was the goal. The more lives you had, it was thought the more business you would bring into the institution. We had a mantra that was 2 million lives by the year 2000. So we grew very quickly. The organization, through some bad business decisions, probably through too rapid of growth, I ran into money situations and filed for bankruptcy and splintered off the Philadelphia and Pittsburgh operations. Had the opportunity to stay and work through the bankruptcy. It was a great opportunity for me. I learned a lot about a business when you go through that. You really get into the guts of the organization. We had to restructure Pittsburgh operations, so I was intimately involved in doing that from a physician standpoint. And then from there, working with the new team that came in from West Penn Allegheny. I worked with them for about 2 years there, and then had the opportunity to go to Heritage Valley as director of finance, which was good for me. I could really marry both the hospital background that I had in finance as well as the physician finance background, and worked there for the first 5 years as their director of finance, and in the last 7.5 now I've been the Chief Financial Officer of the organization.
What's your educational credentials?
I have a Bachelor's of Science in Accounting. I went to St. Francis University in Loretto for undergrad. I was out of school for about 3 years or so, and really had to make a decision. Do I want to really look for a CPA, or do I want to go the MBA route? So I went the master's route, actually from Robert Morris, and went there at night. I worked days, went to school at night, didn't have much social life. I got that done in about a 3-year period, and it was great. It was a really great program, and I think it really helped me to advance my career.
Some of the questions that the students have had is how to balance a very busy work life with going to school and all, and you've summed it up. You don't have a whole lot of extra time to do it, but you got to balance family life and work life and school life. Sounds like you were able to do that.
Yeah, the priority always was the work. The second priority, I hate to say it, was the school, and then you have your family life at the same time. But I think the one thing, I think you're so much more focused in the graduate environment. You were an undergrad. I know I wasn't quite as focused in the undergraduate environment. I think you had a lot more time on your hands because that's all you did. But when you have work and you have school and you have other commitments, that you need to really just focus and do what you need to do, and did really well in the program.
You ask a busy person to do something because usually they can fit it in because of being so organized and structured.
And I think when you're completed, and you always look back and say, how did I do it? Because it seems like you would never have enough time to do it once you're done.
Right. Describe the finance department at Heritage Valley. You're the chief financial officer. How does it cascade down to the other employees? What departments and who reports up to you?
Well, the typical finance department, so I have a director of finance who really handles accounting, disbursements, which is accounts payable, payroll, handles that end of it. We also have a physician finance arm, so if you look at it, we have a hospital finance arm and a physician finance arm that handles all the really accounting, reporting, analysis for those organizations. We also have a decision support area responsible for the budgeting and the ongoing really analysis and monitoring on a monthly basis. I also have the patient accounting responsibilities for the organization, so the billing side of the equation. And again, separate shops. We have a hospital billing shop that sits in Baden, which is really halfway between the two hospital facilities. We have roughly 40 individuals there who work from getting bills out the door to collection to follow-up. So it's a pretty massive operation. It really is, when you look at receivables, it's the lifeline, it's the blood of the organization, because that's where the money's coming in from. We also have another shop up in the Beaver Market which handles all of our physician billing. We have 3 wholly owned physician corporations. We employ roughly 150 physicians. That organization brings in over $80 million a year in cash. So again, very important, and again, that function rolls up under my direction as well. I'm also responsible for materials management and distribution in the organization. I have a manager who runs that for both facilities. So from the storerooms to really all the other clinical inventories, which are large for us, operating room, the cath lab, diagnostic imaging, all the radiology areas, laboratory, dietary. So a number of these areas all have inventories within. Our goal is to really do the best job we can in managing that inventory to make it more a just-in-time inventory, not a just-in-case. Because everything that sits on the shelves in our world is money. So you want to have the least amount of money on the shelf, but yet be able to meet the needs of the physicians and the patients of the organization. I also have medical records and coding, very important. Again, as these services are provided, you want to make sure that the coding is appropriate for the level of service provided, that we can get the record signed off on a timely basis, because coding and record attestation and sign-off is what's needed to get the bill out the door. So again, another very important function of that organization.
Yeah. So if you keep it too long, then the bill gets too old, and that also documentation is so important for finance too.
And you have timely filing requirements. There are certain payers that only allow you X amount of days to get a clean claim in, and if you don't get it in within that time frame, then the payment will be denied.
Describe a typical day for you.
Typical. There is no such thing as a typical day in the finance world. I mean, really my job, if you really look at it, strategic finance direction of the organization. So work very closely with the senior team members. We work as a team. We meet on a bi-weekly basis. Usually take about 4 hours every Friday morning. Again, working around the room from finance to human resources to technology, quality, just making sure that we're really all marching in the same way, we're all rowing the same way for the organization to keep on the same path. And again, my goal is to really safeguard the assets of the system to ensure that we have positive financial performance and really improve on the performance and make sure, you know, when you look at it, our job should be to leave the organization better than when we found it. And that's really what we try to do. My job really on a daily basis, really a number of things. Obviously financial statements and being able to report results. I have to work with bond rating agencies. We work with all 3, so Standard & Poor's, Moody's, and Fitch. In fact, we have a rating review coming up in April, so I've been dedicating a lot of time to preparing for that review. There's a lengthy questionnaire we have to complete. Myself and the CEO will do the presentation to the members of that committee, which are San Francisco and New York. And yeah, it's very important because that's really our report card, if you will, from a finance perspective. The grade that you get on the rating is going to say, if we want to go to the market to borrow funds, what's the cost going to be? So the higher your rating, the lower cost of the funds.
The students don't have a whole lot of knowledge on rating agencies. Can you just go a little bit more into, you know, what it means to be a or AA or B plus, or how that rating's determined and what it means?
Yeah, the ratings really determined. They look at a number of facets. They're going to look at the market that you work within. So there's a market component to it. Governance is very important. They look at the structure of the organization, the board, senior management. How long has the senior management team been in place? Has there been a lot of turnover in the organization? And of course, always at the end of the presentation is where we start to talk about the numbers. But clearly, they're very interested in your strategy, your direction, where you've been and where you're going to, especially in a time now with the Affordable Care Act. all the changes in healthcare is an organization, where do you see yourself? We're going through massive change now where we have inpatient volumes declining, more of the services being provided on an outpatient basis. Our goal is to get care to the community, where the community sits, to make it convenient, so it's access, cost, and quality, really the triple aim, if you will, of healthcare. But it's important because the rating agency needs to know what your goal is and where you see yourself in the future. Again, they're going to look at present results and where you've been, sort of that trending. But it's important because the higher you are rated, again, as you would go to the market to borrow funds if needed, again, the cost of money would be less. It's also important, too, because anybody who's looking at, eventually, if you were looking at any potential partnerships with other organizations, and even from a purchasing perspective, you're going to do some large deals, which we've done in the past on, say, diagnostic equipment, or we bought all beds for our new hospital facilities. It's a lot easier for me to negotiate favorable terms when I can say, here's how we're rated. We're a strong organization, we have higher ratings, and I can really negotiate them much better financial terms.
It's kind of like going to the bank yourself and going to get a loan, and your credit rating is a high rating, you'll get a better interest rate or a better deal with the bank.
Exactly. It's very similar to a FICO score would be for an individual.
Budgeting is a big part of finance in a hospital. Can you describe what the budgeting process is at Heritage Valley?
Sure. We have two budget processes. One would be for capital. And again, in our world, capital is dictated by Medicare, which says any item that's a single value of $500 or more with a useful life for 2 or more years would be considered capital. Everything else would be considered an operating expense. So we have a pretty extensive capital process. In fact, we don't call it a budget, we call it a plan. We have an ongoing 5-year plan. It rolls every year. We're currently in that process now. It kicks off in January. We work with a capital budget subcommittee of key members of the organization, really from all facets. If you think of it, information technology, almost every item you buy today, whether it's equipment, systems, diagnostic imaging, everything has an IT component related to it. And those items need to talk with existing systems, so it's very important to have our information technology on the team. Clinical engineering, because they know the equipment in the organization better than anyone else. They pretty much know what's old, what needs replaced, or on the other hand, what we can still continue to use and maintain. We have our key members of our clinical side, from our chief nursing officer, our vice president of surgical services, and others in the organization that sit on this committee. And we develop the key, we call them the 5-year plans and initiatives. So if you look at those diagnostic imaging, because there's a large investment in that on an ongoing basis, information technologies and the annual large amount of money for us, especially as we move forth meaningful use, and all the things we've had to do with electronic health record and systems over the last few years. So we've really spent a lot of money in that area. And of course, making sure that the infrastructure for the facility is sound. You want to make sure it's a safe environment for patients, that we can treat patients in the manner they're accustomed to and expect, making sure that the facilities are aesthetically pleasing but also safe and sound. So we go through that process. Our capital plan usually kicks off in January. We end the process here. The fact the forms, everything needs to be in by the end of February. Probably with about a month in March, we'll work closely with the senior management team to narrow down. We know what the target is because we do the analysis to say, based on our current operations, based on what we expect for the next year, how much money we can deliver from an operating perspective and how much we can afford capital-wise. At the end of the process, once we are comfortable internally, then we do take it to our finance committee. We'll take it at the beginning of June, and we'll go to the full board at the end of June for approval. At the same time, we kick off an operating budget process. So every department head, again, would be required to budget, again, their operating expenses, their FTEs, in our world, full-time equivalent, which is the staffing. Very important, because in healthcare, staffing's roughly 50% of our overall expenses come from staffing. So it's a labor-intensive type of operation. So they budget their staffing, they'll budget all their other direct operating expense needs. We work closely with them. At a senior level, we sit down and we'll work and develop what we call demand statistics. And that will say, for the next year, what do we think volume is going to be from an inpatient admission basis, how many patient days, how many emergency room visits, and a lot of those will really drive what the individual department statistics will be. So in the case of nursing, how many patient days by floor. So once we've developed the overall targets for admissions and length of stay in days, it's pretty easy then to drop it into what floor that would be. Diagnostic imaging, we know we do so many procedures per admission. Pharmacy, how many line items per patient day, so it's pretty easy then to develop your budgets once you have the key statistics set. You know, in my world, I sort of look at it and say, if you spend more than 3 weeks on a budget, I think you're wasting your time. And a lot of people sort of sit back and say, well, why would you say that? The budget's a good tool, the budget's a guide, it's really what you want to work from, but I'm very thoughtful and mindful of, manage your actual, not your budget. So again, we have a pretty condensed process. It takes us 3 to 4 weeks, we get it done. It's good, it's a great tool. We actually run very close to our budget on an annual basis. So again, I don't think it's the quantity of time you spend, it's really the quality of what you put into it.
You know, whenever we were talking with Dr. Alan Yasted from St. Clair, and we were talking about the budget process and trying to speculate what a physician is going to do in the next year, sometimes it's difficult because you don't know, there's government changes things, physicians may leave, physicians may decrease their, so it's very, it is a forecast. It's not something that's written in stone because it's going to have some wiggle room in the based on the changes that are happening. One of the questions that a student had raised was, how do you keep them within the budget? How do you, as you roll out the budget and knowing that it's just a plan, do you find that it's difficult to keep people on budget, or is it something that has been very well practiced at the hospital health system?
I think it is one of the roles of the chief financial officer to ensure that there is compliance to the budget. We have the tools in place. We have a very elaborate and extensive budget monitoring system, a decision support system that monthly reports go. They're online. Each department has access to it. We actually give us a variance analysis report. We developed the criteria if you're so many dollars, either so many dollars and or a percentage above your budget target, then an explanation is required on a monthly basis. And the explanation needs to include not only why, but what are you going to do to correct that. We've done very well with this program. I think our department heads are very cognizant of the fact that they need to manage within their budget targets, and especially in the area, again, of manpower, because it is such a large component of our overall expense. So, again, we have very good compliance. We've probably run the last 5 years in a row, I could say we were actually under budget on our operating expenses. The other side of the equation is the revenue, which you have sort of less control of because we don't control on a direct basis when patients present themselves for services. The one thing I will say, I actually tell the Finance Committee and Board this every year, the budget is as good as the day we put it on the table, because I could change it the next day, because as you say, there's always things changing constantly within the environment. And again, I think it's a guide. It's really what we want to get to. Our goal overall is to hit a certain margin percentage, and again, that's dictated by the board. And really dictated between the board and the rating agencies, where they're saying to be successful, to maintain your rating. In our world, they want a 3% operating margin, which means 3 cents on every dollar that comes into revenue. They want to see hit the bottom line. So our budget's predicated on that, and we try to manage to that.
One of the questions also was, how do you determine employee compensation? And based on, is there a rule of thumb that people use to say a nurse is getting paid this amount and a nursing assistant will be paid X amount? And anything that you can add to that as far as how do you determine compensation levels?
Yeah, so that's a very good question. In fact, we do that through our Human Resources Department. We have a Director of Compensation and Benefits who rolls up to our Vice President of Human Resources. And we engage an outside party. Again, that can look at it from a market perspective. Our goal and target is to pay at the 50th percentile for all positions within the organization. So those market studies are done on an annual basis and will tell us where either we're over or under market. In those cases we're under market, we will adjust. So those employees within that job class, we get an increase to get them back to the market. And for those over the market, again, depending on the level of overage, there could be a time where you'd say, I'm just going to sort of redline you for right now. We'll give you an increase, but it would be more of a sort of a one-time payment. It wouldn't be an additive to your base to try to keep them in line with market.
You mentioned operating margin, and you mentioned 3% operating margin. Can you just elaborate on what operating margin means to a hospital? What are you using that 3% return for?
Well, in our world, as we know, we're not-for-profit. We're 501c3 organizations, so any of the remaining funds, be it profit, and even on a cash flow basis, you look at that, aren't paid out in dividends, don't accrue to anybody individually, that's the money we're using to fund the capital plan. So what we do is we have an account, actually it's called funded depreciation, and what should happen is if in the world of both the rating agency and really good stewardship from a finance perspective, depreciation is non-cash. So when you look at your profit and loss statement, although it's an expense in there and it's really does drive your operating margin, from a cash basis, you sort of pull that out and say, I need to fund my level of depreciation expense annually, plus anything over and above that I accrue in earnings, I'm going to put into the account to pay for capital. And that's how we do things. Again, it keeps you on target because almost like in your own home where you'd say, geez, I know I make X amount of money, I have certain operating expenses I want to budget, be it I have to save for future, whether it's retirement or a home purchase or a vehicle. Obviously, nobody wants to overextend themselves, and like us, we want to make sure that there's always money there to replace the equipment and facilities that we need.
Besides operating margin, what other metric do you use to determine financial viability of an organization?
There's probably, I'd say, 5 or 6 really key. And again, I'm going to say rating agency. A lot of times you're going to probably get tired of me saying that, but when you look at it in our world, there are balance sheet indicators, and there are then the profit and loss indicator. So as we talk about operating margin, that's a key profit and loss indicator. Again, it's coming off of your statement of operations. Total margin, again, the total margin would be what you generate from operations plus any non-operating investment income and other revenue generating items, which should give you a total margin percentage. I think we look at it as very important for us, and our management team knows what's our personnel cost as a percent of revenue. So compensation being salary and benefits in total, what are we paying at? So what are we seeing coming in the door? The revenue being the denominator, the expense being the numerator. We want to keep that number at or below 50%, because when we do, we know we're profitable. And so what that says is, in the case, say it's 49%, so 49% we've spent to generate the dollars coming in the door. So that's a really key indicator for us. If you go to the balance sheet, we look at days cash on hand is really standard across the industry, really in any industry, meaning how many days cash do I have on hand that if I didn't take another nickel in from today, how long could I sustain the operations of the organization? In our world, we run about 250 days cash on hand. So meaning if we didn't get another nickel in, if some catastrophic event happened, we could probably run the organization for about an 8-month period with any funding coming in. Clearly, is the number needs to be, from a rating agency, they're looking for anything probably north of 150. When you get below 100, it's a red flag. I mean, there are organizations that do run that, but I can tell you that their ratings are probably going to be BBB or junk bond ratings.
Yeah. How about your charity care and uninsured? Do you have much in your business area, many people that are coming in without insurance?
We do. We have our self-pay has increased over the years, especially now as more financial responsibility has been shifted to the patient. And if you think of one thing, I think the Affordable Care Act has done under this arrangement now too, the employers have multiple options, saying you can go to exchanges or we can offer high deductible plans. All those really do is push more financial burden on the employee or the patient in our case. So we're seeing a lot more activity of we call no pay, self-pay. First thing we would try to do is anybody that does not have insurance is we try to qualify them for the state medical assistance program. And we work actively on that. If somebody is an inpatient that's admitted to our facility, we work with them while they're in-house. We actually engage a third party to do that for us. It's been successful. We're working on the outpatient side as well to do the same. The hardest part for us is to have the patient complete the paperwork. A lot of times, I think you get in a situation where maybe you're in a tough spot, you've lost your job. People are proud. They don't want to admit that they don't have the funding, they don't want to complete the paperwork, and they just don't pay the bill either. I think the one shift we've seen in the credit world is our hands are tied from a legislative perspective of what we can do from a collection standpoint. Healthcare, we can't put a lien on property. We have to be very careful of how we really attempt to collect the bills. So we're governed by certain rules and regulations there. But we've also seen is even though we can put the account on credit, meaning if somebody goes to your credit report, they would see you have an outstanding debt to our organization. A lot of entities out there now pretty much just have devalued that and said, well, it's okay, it's health care, I'm not going to worry about it, and we're going to give you the loan. So it makes it much more difficult for us than to really collect.
Yeah.
Charity care, we love to provide charity care. That's what we're there to do. Again, being a 501c3 organization, we have a charitable mission. We want patients to have their care. We want them to maintain their wellness. So again, we treat everybody regardless of the card. We treat the patient, not the insurance card or lack thereof. It's just difficult. You wish more individuals would complete the paperwork because they would qualify, rather than just them being considered bad debt. And as an organization, charity care to us is important because we report that on our tax returns. We have to do annual 990 tax returns, and it's really to justify, if you will, the tax exemption. There's a whole section in our hospitals of how we justify that, who we serve, what we've provided in charity care, what we've provided in overall uncompensated care, so that's important for us.
You know, there's been a lot in the press about UPMC and whether they should be considered a profit or nonprofit organization and continue their tax exemption status. Anything that you, regarding UPMC being such a large entity, having some, for-profits arms, any comments that you have on that, whether they should continue their non-exemption status?
I believe they should. I think in healthcare, as I sit back and look at it, a lot of times people equate profit with tax exemptions. They're saying, as a business, we don't want you to make money to have your tax exemption. Let's be frank, if you're a business, you don't make money, you won't be in existence. So there has to be some level of profit. I think in UPMC's world, when you look at the profit, the numbers are large because it's a large organization. However, when you look at their operating margin, if you look at last year's margin was 0.8%. Heritage Valley, a much smaller organization, we're a $450 million organization, we had a 0.8% margin. Through the first 6 months this year, UPMC had a 1.9% margin, just publicized in the Post-Gazette. We had a 1.9% margin. So when we look at it, we're very similar. They're just larger, so the numbers look larger. I think they've done a good job in looking to say where we have for-profit entities, they're classified as such, and those entities pay taxes, just like our for-profit entities would. I know they have a large amount of property in Oakland, and there's always that struggle between, you have this large amount of property which doesn't pay property tax, but I think they've been very fair with the Pittsburgh Promise, their funding of that initiative, the other pilots, which is payment in lieu of taxes that they've done in the past. And again, if you sort of strip them of that, and you want them to operate in a real for-profit world, I think you'd see a definitive change in how they deliver service. They're not going to be servicing patients who don't have the ability to pay at that point, because for-profits don't do that.
One of the things that we've been discussing in the class is about people that are coming into the hospital that don't have insurance, and they're charged 100%. And if you have Highmark, they might be paying it 60%, or some of the students were unaware that people were paying different rates when they come into the hospital. Can you say anything about that as far as the rates that Highmark or other commercials or uninsured, the percent that they pay?
Okay, so just a quick, I guess, a reimbursement update. If you think of it, think of governmental first. You'd say you have Medicare and medical assistance. There is no negotiation. You sign a participation agreement. So as a facility or as a physician, I agree to participate in the program. I agree to accept your payment. We don't negotiate rates. The only difference in Medicare payments, really in the area, or if you look at it geographically, is wage index. Very important. Pittsburgh is one of the lowest wage index areas in the country. Everybody starts with the same base rate across the United States. So as an example, let's say the base rate's $5,500. That base rate is then multiplied by the wage index. Ours goes down. Our wage index is about 0.86. So we get 86% of the base payment. We just did an analysis that said if we could move our facilities to Harrisburg, only 3 hours away, not much difference between Pittsburgh and Harrisburg, our organization would have $6 million more in revenue because they're over 0.9. So you can see there, that's the only real difference in the Medicare side. Again, medical assistance for the state, unfortunately, is a very low payer. But as you look at commercial insurances, so if you look at Highmark, UPMC Health Plan, Aetna, Cigna, we all negotiate with them separately. We cannot disclose those rates. They're in gag clauses within each of the individual agreements or contracts. So individual hospital organizations sort of can't compare, if you will, what we're getting paid for services. But needless to say, we charge more than the payment for the service. A lot of times you say, well, why do you do that? There are language in almost every one of the contracts. It's called lesser of language. So if you look at Highmark, Cigna, again, Aetna, if we charge less than they're willing to pay us or we negotiated, we only get paid the lesser of. So you always want to make sure your charges are at least set at rates that are equal to or higher than the reimbursement that you're getting in. What we've done more from a self-insurance perspective is we discount. So we know we have a charge structure in place that's 100%. We discount charges 55% for the outpatients. So we're saying is we expect you to pay 45% of the charge, which is pretty much in line with what on an average basis would you receive overall if you sort of looked at all of your payer mix, so to speak. From an inpatient perspective, we actually discount that down to, again, Medicare and the medical assistance rate, so we discount that rate down significantly. Again, we're not there to gouge the public. We want individuals to have the care. We really just want to be able to be paid the cost for providing those services, hopefully make a little bit of margin. But I can tell you, setting it at a medical assistance rate, we lose on every medical assistance patient that comes in the door.
Wage index, why would Pittsburgh be that much different than Harrisburg?
You know, I think a lot of it comes, if you look at the two largest organizations, you have, again, the Allegheny Network and you have UPMC. The Allegheny Network, unfortunately, went through the bankruptcy process, and I can tell you from working here probably the 2 years prior to bankruptcy, there were no wage increases at all. We were flat. So as we had very little wage movement, I would say, within the Pittsburgh area. Other areas of the United States, New York, California, Texas, were giving increases that maybe even approached between 5 and 10%, so that gap continued to grow. Mm-hmm. And again, this area's been pretty stagnant as far as wage increase over the years.
Auditing is a big part of finance, you know, making sure that you are doing what you're supposed to be doing. What type of audits do the finance department go through?
Well, that's a very good question. First is, probably recommend anybody in the future, if you're going to be in the world of finance and healthcare, have an internal audit function. We do have an internal auditor on staff that came from corporate finance and worked at Alcoa and a couple other corporate entities. She reports directly to our audit committee. So again, sometimes people think an internal audit reports to CFO. That's sort of like the hen, fox guarding the hen house. Clearly, she works independent of me. The CEO and myself meet with both the internal auditor and our director of corporate compliance on a bi-weekly basis, really to keep us more abreast of just what's going on in the organization and the issues that they see arising. But we have, again, our internal auditor doing a variety of audits during the course of a year. She has an audit plan that gets approved by the audit committee. And some of that could be related to the cash function, very important. You want to make sure you safeguard cash. All organizations in healthcare, you do take a lot of cash in with co-pays at physician offices or even at the windows at the hospitals. So one, that's very important there. Two, from a compliance standpoint, are we billing appropriately? So between compliance and an internal audit sort of falling up on the backside with that as well. And then as far as really just looking at it from a payment perspective, so auditing payroll and accounts payable and making sure that everything we do is, again, above board. And again, would meet external audit, because if you can keep yourself clean from an internal audit perspective, your external audit should go much smoother. We also have external audits done, of course, from a financial perspective, but there are many other audits that occur within an organization. Again, we are a Joint Commission facility, so Joint Commission comes in and does reviews on about every 3-year basis. And they're very thorough. They're more clinical in nature. They're really going around the facilities. There's the life safety component. There's the clinical component. Again, with governance and organization, one of the first things they do, they'll do an entrance conference. And they have pretty much everybody from the senior team. We have board members, and they want to know about the organization. What do we do? How do we do it? Where's our policies and procedures? Very important. I know nobody really likes policies and procedures. I'm not a fan either. You have to have them. I hate writing them, I'll be honest with you. But they are something that's needed in really all crosswalks of the organization. Internal audit really helps us with that because she's very focused on the policy and procedure. But and then you have, of course, Medicare. You have Medicare audits. We get audited for cost reports that we submit annually that we're required to submit, almost like tax returns, if you will. Medicaid cost reports. And we've been hit with a slew, and I think anybody you would talk to in healthcare, there's a slew of audits now on individual patient accounts.
Mhm.
As we continue to move forward, payers are being very tough to deal with. They're auditing various accounts for various reasons, and we have to really prove that our documentation's in place, that we should get paid for what we billed for. And I can tell you it's an ongoing process from what's called RACs, from a Medicare perspective. That's Recovery Audit Contractors, where again there's multiple accounts throughout there over a multiple year period to go through a process of review. They'll deny, we appeal. It's just an amazing process, the amount of audit work that's done on all these. So many audits, many fronts.
I think that with the Affordable Care Act and the Obamacare saying that there's so much fraud and abuse in healthcare, thus the RAC auditors that come out to, their job is to find problems because they get reimbursed based on what they find in hospitals, correct? And it's,
Yes.
their job is to be looking for those things that are possibly fraudulent or abuse. Turning to sequestration, I think sequestration was a word that came out in healthcare, and I remember hearing it thinking, what in the heck is sequestration? What is sequestration and how has it affected Heritage Valley?
Well, from my personal opinion, my perspective, sequestration is really a payment reduction on healthcare. What it was something through the budget process, a congressional house, again, really up to the presidential level, to say that if we didn't meet certain budget targets as a nation, that the sequestration would kick in. What sequestration did was reduce payments to hospitals and physicians by 2%. So we've been living under that for probably the past 3 years, where our Medicare payments are reduced by 2%. Not only the Medicare fee-for-service, which is the pure governmental program, but the Medicare we call health maintenance organizations or managed care organizations. So you have a UPMC health plan has a Medicare product, and Health America has Advantra, and everybody has these different variations. And in our geographic area, these health maintenance organizations for Medicare are large. They're probably 2/3 of our Medicare business. They've all reduced our payment by 2%. And so clearly that's hard from a fiscal perspective. When I sit back and look and say, of our $450 million, we probably have close to $200 million of it coming from Medicare, that there's $4 million of reimbursement a year that just evaporated under sequestration. So I'm not a fan.
Yeah, and that's equipment that you don't get, so the raises that don't get made. Now, the Affordable Care Act, have you, anything you want to add about the Affordable Care Act that has affected Heritage Valley?
I think as we move forward, you can see the definitive shift, I think, in the patient population. Again, our inpatient business over the last 5 years has shrunk significantly. Our inpatient cases 5 years ago, our two hospitals ran about 27,000 admissions a year. We've had about a 20% decline in inpatient admissions, so much more of a shift to outpatient setting. Again, an outpatient setting is more cost efficient and effective. I think from a patient perspective, probably a little more pleasing because I can go closer to home. I can have my services done. I don't have to pay to park, things of that nature. What we're also seeing though is this, I think, a clear shift, not getting paid fee for service or getting paid for what you do, now getting paid for how you do it. So the shift of value. We've entered into many arrangements on the physician side where we have care management fees in place, gain sharing, if you will, to try to, one, reduce the cost, which is called the medical expense ratio, trying to reduce the cost of services provided at the same time. Again, ensuring, get back to the whole billing and concept too, to make sure that we're billing appropriate and in compliance with the rules and regulations. But I think you can see clearly the shift now to saying we're not going to pay for readmissions, so a penalty on readmissions if your rates are above certain government benchmark and thresholds, and also for the value-based purchasing. So clearly I think we always see up to about 2%, we had a discussion earlier this morning, about 2% of our payment, they're at risk, if you will. It's in a pool. Those who do well pull back out of the pool, those who don't get penalized. Recent literature would say that government wants to move it to about 30% of the payment being value-based within the next 2 to 3 year period. So a significant change in reimbursement, really significant change in philosophy for a healthcare provider. And I think spending a lot more time and effort and really building an infrastructure around quality analytics, and data to be able to sure you can really measure, because if you can't measure it, you can't manage it.
Mm-hmm.
So we have to be able to manage that and do what we need to do to be successful in those programs.
Now, meaningful use has been brought into play in the last couple of years, not necessarily a financial initiative because it's more IT, but you've been able to gain dollars based on meaningful use. Can you mention anything about meaningful use and how it's affected Heritage Valley?
Well, I think it's affected every organization because, again, as the government has come out, there's a large thrust towards the electronic record and being able to maintain, again, all the patient activity within that record to eventually get to a health information exchange that would be on a national basis. It's hard now to even work on a local, but I think having the information is key. I think there's benefit to a health information exchange. We've seen it even internally here in our role, but nonetheless, to get back to meaningful use, really required organizations spend a lot of time, money, and effort to put these systems in place, to become electronic, if you will, from a clinical perspective, at the hospital level, at the physician level. What we've done is we've been able to negotiate a deal where we've been able to pay, if you will, our third party for these softwares and hardwares over a period of time, and then once you meet certain requirements, you have to attest. There's a year one attestation we've been successful with. We did our year two attestation, we were successful with that. Now moving to stage two, and the criteria just gets more expanded, more difficult to meet as you go forward. But there is federal monies that come back and also from the state that helps to really defray some of the cost of the investment. It will never cover the true cost or total, but at least defray some of the cost of the investment in these really computer software and hardwares.